Assalamu alaikum and welcome to Medicower. I'm your host for the show, Robina Mir, and today's topic's very much of interest, I hope, to all of you, but one of those topics that sometimes we don't talk about very openly, about the care of those who are in the last stages of life and so are dying or in a long-term illness where there's no cure for them. So today's topic is very much around hospice care, what you can expect from a hospice, how hospices work, and what's involved with palliative and end-of-life care. In the hot seat today is my guest, Amy Dunmall. Amy is an education lead for Wheatsfields Hospice in Leeds, and she's very kindly come across to talk to us about end-of-life and palliative care. So thank you very much, Amy, for being here. What is end-of-life palliative care? What do we mean by those terms?
Well, I think there are two different terms there, and palliative care is a more global approach or a wider approach to how we treat people who have a life-limiting illness.
Okay.
So it's a very holistic approach, looking at people's physical, psychological, emotional, spiritual and social challenges around facing the end of life or facing a terminal illness.
Sure.
Whereas end-of-life care, I tend to think of it being around the last few days or weeks of life, around some of the real practicalities of supporting someone as they approach death.
And you very much attached to hospice care. So what is a hospice and how does it compare to a hospital?
So I work at Sue Ryder Wheatfields Hospice
Yes.
in Leeds, and the hospice model is about that palliative approach, about supporting people holistically who are facing the challenges around end of life. We may see people much earlier than just the last few weeks or days to provide symptom management and support for them and for their families. How that differs from a hospital is that hospitals are predominantly geared up to treating people and curing people, and possibly a much shorter turnaround. You know, for example, you may have an acute illness that requires surgery, perhaps a knee replacement or a hip replacement, and there's a very curative focus. So that's the fundamental difference. So
this is about, we can't cure, but we can help you to have an easier and more comfortable time towards that end stages of life. Yeah.
So our focus is very much around quality of life, and there's a strong holistic focus, so involving the family and your psychological, spiritual and social needs, not just the physical. I'm not saying that hospitals don't provide that, because I think hospitals possibly do. In Leeds we do have a palliative care team within the hospital as well who provide significant support to people. But our focus is not around cure, it's around supporting people to have the best quality of life as they're approaching the end. Okay.
So how close to death is somebody before they come into a hospice? I think in my experiences, when I've had relatives that have come to a hospice, it's because they've been in the literally last few days. Is that normal?
I think it varies. It's very, very dependent on what a person may need. So we may meet people much earlier in their disease process who might have specialist needs for managing their symptoms. So perhaps somebody's in pain or they're feeling nauseous or sick, and we can assess their symptoms and tweak their medications to support them, and they often go back home. But we also do see people around the last few days or weeks of life as well. So it depends on your individual circumstances and what your needs are. So there isn't a black and white, this is what we do, this is what we don't do.
Yeah.
We work with what the patients need.
Okay, so this is very much an individual package of care then.
Yes.
And how, what part does the family play in all of this?
We very much embrace the family with the patients. So when our patients come in, we provide a holistic assessment, and we're really careful to ensure that we involve family or carer or significant others in the assessment process, what their needs might be, what their support needs might be. So very much involved in the care and being cared for.
So Because I think for me, one of the daunting things about a hospice was thinking you can't step into a hospice unless you've got somebody there. How can people learn more about hospice care before they're actually in a situation where they might need it?
That's an interesting question.
And should we just wait till we need it?
I mean, I think to be invited here today is a really great opportunity for us to share what hospice is about, and I totally agree. You know, it can be really daunting, and in my own personal experience, having to go to a hospice for the first time, I was quite frightened. So how do we break that? I don't know. I don't know the answer to that. I think
it seems like an intrusion on people's privacy when, you know, you can walk into a hospital because you're visiting others, but you can also walk into a hospital because you think, you know, they've got a nice shop there, we'll go and have a look at. And Sue Ryder, your hospice, has some lovely gifts on, you know, because they're fundraising. And I think, you know, when I turned up today, I was thinking, you know, I wouldn't mind popping back to just have a look at the things that you have on sale there, because some nice things there. But then am I intruding on that space where there are people there for more serious reasons?
We very much welcome people into the building. Probably not into the clinical area, but we do welcome people into the building. We have beautiful gardens.
You do?
And we have, we up until recently had some on-site sales, which we are just renovating at the moment, and have always welcomed the local community to be part of that and help us with our fundraising. We also have a day hospice.
Okay, what does that mean?
Many of the, I know St Gemma's in Leeds also do many of the other hospices locally. So our day hospice provides almost like an interim between the main bedded area and the community. So you can come and be part of the hospice, patients and families, and meet the team, have your symptoms assessed, but not need to be in an inpatient bed. So there's a bit of a bridge there, and there's an opportunity there to find out a bit more about who we are. But you probably wouldn't meet that unless you had a diagnosis that required you to be there. But we have Christmas fairs, summer fairs, and openly welcome our doors to the local community.
I think I've seen it advertised also on the local Freegal, where you know, you've got fundraising days, and so that's, I guess, looking for those invitations as well.
The doors are open. We couldn't have people wandering around the clinical area, but we absolutely feel very much part of the community and want people to feel welcome.
Yeah, that's really good to know. So, are the staff that are involved in a hospice the same kind of stuff you might find in a hospital? I'm still trying to understand that variation and you know, what kind of skills are being used. Who's in the team at a hospice?
So in the team at the hospice, we have a really wide-ranging team. So we have consultants, we have registrars, so there's a medical team. We also have nurses, qualified nurses, nursing assistants. We have physiotherapists, occupational therapists, we have a family support team who are a team of social workers, a spiritual care coordinator, bereavement coordinator. So there are a large number of professionals within the team who you would also find in a hospital. Our staff will have the same professional skills as you would expect in a hospital, and may have then also specialist skills that enable them to work with people who are facing life-limiting illnesses. Yeah,
because this is a sensitive area. This is an area where we need to have empathy and compassion and the right words to make sure that we're in contact with people in a way that's supportive rather than saying the wrong thing. So that's where your role comes in, doesn't it? Your educational role?
Yeah, so we do, our staff are trained in communication skills and symptom management skills, and I do play a role in facilitating communication skills and supporting staff with, dealing with patients and their concerns.
Lots of people worry about what to say to somebody that's got a terminal illness. What advice would you give to people about how to handle that? Or is that something beyond your remit?
I would always say I think it's very individual, and that people facing a terminal illness, my guess is that what they want is to be treated with dignity, respect, and to have their concerns heard. And that's very much what the training is about hearing how it is for that person, being alongside them. I don't think there's any one thing that you could say. You meet each individual where they are and find out how they are, and providing empathy, as you say, and compassion, and that might just be, I'm guessing this is really difficult for you.
So if I was visiting somebody in the hospice, what kind of times can you visit people? Are there set visiting times like there are in a hospital?
We don't have set visiting times. We have an open door policy.
Okay.
And you can pretty much visit any time that you like. That may be dependent on what the patient needs. So the patient may put restrictions on for their own health and well-being, but the door is open.
Okay.
And we have people stay. We've just renovated a family room so that we can provide overnight facilities for families needing to stay close to their relatives. And we're just about to improve another space as well, so that we have more space for families to be able to wait and be close. Because
we don't know when death's going to come, so it's a case of, being around during those periods of time and not having to go home all the time.
Absolutely.
That sounds really supportive and it sounds like the right thing to do, so it's good to hear that. Thank you. Does everybody in a hospice get their own room?
In our hospice we have 18 beds. 15 of the beds are private rooms and 3 are in a bay. We tend to predominantly use the private rooms. I know at St Gemma's in Leeds, our colleagues there, they have 36 beds and they are all private rooms. And we really acknowledge the need for people to have privacy and dignity.
Absolutely,
at such a sensitive time, but for the patient and for the family. So
I think in my head I was thinking you kind of hope you're going to have your individual space because of that stage of your life coming to an end, but in my head I was thinking, oh my God, there are people on wards and we all having to have curtains around, and that didn't. So it's really lovely to hear that those facilities are available. It's one of the things I don't think I would have known had I not spoken to somebody like yourself from a hospice.
And the rooms where we are go around a courtyard with a pond, and we sometimes wheel patients out in so that they can be outside and experience nature and the pond and the peace there. So it's a nice environment.
Yes, I noticed that when I came today. What other services do hospices provide?
We have a large I forgot to mention them. We have a large community service. We have a team of community nurse specialists, and they see I think it's over 1,000 patients a year. A large proportion of the community we provide support to at home.
Because not everybody wants to be in a hospice, do they?
They don't. And we really support people to be where they want to be, with the people that they want to be with. So our nurse specialists work very closely with general practice, district nurses, and supporting people with their symptoms and supporting families at home. So that's a big component of our service.
And how often would they visit somebody at home?
It would be very dependent on what the patient needed.
Okay.
We tend to see people who have more complex or challenging symptoms from that team, and then work very closely with the district nurses who provide, the district nurses provide a large proportion of palliative and end-of-life care in the community and at home.
So there's no set time frame for this, it's more a case of, again, that bespoke service that's all around the needs of that individual patient and perhaps also the family that's... How close do the patient and the family need to be in sync for them to get support?
How can you repeat that?
Just how close in sync, because I'm thinking sometimes as a patient you might want something different to what your family wants, but your family are concerned about other things to do with how things happen for you. What happens if there's not total agreement on what patient and family want?
I think our role is to listen to the needs of the patient and listen to the needs of the family and find a way to work with both, because there will be different needs.
Yeah, I would imagine
you're facing different challenges. So our role is to very much listen to all the concerns and what all the needs might be, and then come up with a plan that's going to support everybody in the most appropriate way. I don't think there's any one which way. The family support team who work very closely with the families, so we have social workers, and that very much is their role to meet the needs of all, and you're not going to have a one-size-fits-all.
No, and it's refreshing to hear that you know that is part of that process. So does that also include continued support for family members after their loved one has died?
Yes, so our family support team provide support for people after their loved one has died. We also have bereavement counsellors and volunteers who provide bereavement support after death. Usually contacted about 6 to 8 weeks after your loved one has died, and there is an offer there of support if that is what's wanted.
Okay.
And we also have fairly recently we have befriending volunteers as well, so we're incredibly lucky to have over 250 volunteers who support our services.
So how do you become a befriending volunteer?
You'd need to apply. There is a process to go through, and there's training. So we provide a rigorous recruitment process and training for all of our volunteers. But that would be how you do it. But you need to have an interest in people and being with people and wanting to support. So that's a newer part of our service.
Do some of these befriending support services include people with other language skills?
They might do,
Yeah.
and that might be something that we want to develop more.
Yeah.
And
Might be worth us encouraging our viewers to think about,
yes,
the fact that we may have gaps in those services.
absolutely, and we would openly encourage people to apply from all different backgrounds. We do work with interpreter services when needed to.
Yeah.
Yes.
That sounds really like a nice task to have, even though it's going to take, it wouldn't suit everybody, I wouldn't imagine, but it sounds like a real benefit for our community to be able to contribute to supporting others.
Yes.
Especially if they're people who don't have families close to them or around them.
Yes.
Yeah.
Yes.
Is that how they're often used,
Yes.
befrienders?
Yes.
Yeah.
Yes. So people who've been recently bereaved or bereaved, or who are caring for another person, may feel particularly isolated and really benefit from having some social support at home.
These services sound like they've been ironed out really well. I mean, everything you're saying to me sounds like, oh, that ticks the box that I was thinking about in terms of, do they do this bit well, do they do that bit well? So who pays for hospice care? Is it free for us?
It's free for those who come who are within Leeds, who are registered with the Leeds GP, and I suspect that's probably the same across the country. The services are provided free, however they're not free. And we at Sue Ryder Wheatfields, it costs 4.4 million a year to run our services. We receive about 1.8 million in funding from the NHS.
That's a massive deficit there.
We have a significant amount to fundraise to provide these amazing services for free for the local community.
So how do you fundraise?
We have a variety. We have a fundraising team and a variety of methods. We're really, really keen to engage with the wider community and let people know about the amazing work that we do and the fact that this isn't fully funded. I
don't think we appreciate that really. I think we just think if something's free, it's part of the NHS, but actually you're not part of the NHS.
No. And Sue Ryder is a national charity.
Yes.
We have 6 hospices across the UK and 7 neurological centres, it might even be 8 neurological centres, all of whom are dependent on the amazing donations of the general public. We have a large retail arm.
Yes,
to
you
the
have
charity.
shops, don't you? Yes.
We do,
Yeah.
and the shops provide significant income for us, so people can donate their unwanted goods, and then that can be used to generate income. We hold events every year. In fact, there's a fantastic event coming up in the early summer, and that's the Yorkshire Woman of Achievement Awards.
Oh yes.
And very prestigious events
It is,
held in Yorkshire,
Yeah.
and that's one of our flagship events. Really fantastic to be part
Where's
of.
it been held this year, do you know?
At the Royal Armouries.
Okay, yeah, I know that
So
venue.
you can nominate and come and be
Yeah,
part of it.
yeah.
Really amazing. So, and we rely on our supporters to fundraise for us and create events and be innovative and think about ways to support us.
So we're talking about Sue Ryder based in Leeds.
Yes.
We've talked about St Gemma's that are based in Leeds.
Yes.
Does every city have a Sue Ryder and St Gemma's?
I don't think they do. I think we're incredibly lucky in Leeds to have 2 hospices. I'm not sure if every city does have a hospice. Certainly some of the cities I've worked in have, and in London there are several hospices. But it will depend, and there isn't a Sue Ryder hospice in every city. There's only 6 across the UK.
So Sue Ryder is one of the names of one type of hospice.
Yes.
How do you vary from other hospices in the services that you give, or are you all very similar, even though you may be from different charities?
think the ethos of hospice care and the philosophy of hospice care, which came from Dame Cicely Saunders back in the 70s, I think it's fundamental to what most hospices provide. So this holistic, person-centred approach. I think I'm fairly sure we all are really behind that, and that's what underpins what we do. How we differ will be our brand and our fundraising and perhaps how we're funded. I think the essence of our care is probably very similar.
It sounds like it needs to be honest with you.
Yeah.
So are we talking about adults care when we're talking about hospice, or do hospices support children as well?
Within Sue Ryder, all of our hospices and care centres are for adults only, and at St Gemma's it's adults. In Leeds we're lucky to have Martin House, who are a children's hospice. So they tend to be separate. You tend to have an adult hospice or a children's hospice, although I do know of some, there's one, I think one in Sheffield where they have both. But it'll be dependent on the area that you live in.
So how do people find out what's local to them?
They may, NHS Choices is a good place to look online for what your local services are, and I think often services are listed there. Your GP should know what your local services and service provision are, and your district nurse.
So who decides who goes to a hospice?
We might have a wish to, we may set, a wish to die in a hospice, or our families may want us to. It would be a negotiation between what the patient needs and the family needs.
I think that's the question I'm thinking about. Why would you choose a hospice? Why wouldn't you choose a hospice? I mean, in my mind, I'm thinking I'd be worried about if I was in a stage of dying and I had a terminal illness, I'd be worrying about my family and the pressure it puts on them to look after me.
Yes.
But at the same time, I'd probably want to be at home because that's where my comfort zone is.
Yes.
But at the same time, my family members might be worrying, how are we going to do this properly? What if we don't know what to do? What if you're struggling with pain? So I'm sort of mulling that over. How do you make those decisions?
Again, I think it's very individual, and we would work with each individual patient. I think first and foremost, it might be about what your wishes are and balancing that with the wishes and needs of your family. We will support people to be wherever they want to be, and you might say, actually, I really, really want to be at home. And what we do know is that we have some fantastic services out there who can support you to be at home. So district nursing, I've mentioned a couple of times, and actually community nursing provides an incredible amount of support for people who are dying at home. We may be reliant on our colleagues in social care. You may need support from them. We have our community nurse specialists, so it would depend, and we'd have to adapt to what your needs were to develop a plan that worked for you and your family. Things might change. You might then think, actually, there's some symptoms here that we're finding difficult to manage at home, so you might need to go into a hospice for a short time to have your symptoms stabilised. Or it may be that you and your family decide, actually, we can't manage, and we feel we need to be in a hospice or in a place where we have more focused care.
You've mentioned the care plan, and I know that we're coming up to the break now, so hopefully after the break we'll be able to talk about that in more detail.
Yes.
But that sounds like there's lots of things that we need to consider. And I know what I also want to talk to you about is how we meet religious and cultural needs.
Yes.
So hopefully we'll be able to explore that soon as well.
Okay.
Thank you so much, Amy. Let's go to the break.
You.
So inshallah we'll see you after the break and we'll continue the conversation then. Assalamu alaikum wa rahmatullah.